So we're back again on MDT discussion for metastatic prostate cancer treatment. And we have a medical oncologist Sadauskienė, medical radiologist Slidevska, and medical radiation oncologist, and also radiation oncologist Vidritskaitė, and me, urologist Kardelis. Online we have more specialists, including pathologist, urologist, medical oncologist, and radiologist. Please. Topic, please represent Dr. Sadauskienė.
Kol kas nematau. Good afternoon, colleagues. I am Jolita Sadauskienė, medical oncologist from National Cancer Institute, and I would like to present case report, metastatic prostate cancer treatment for MDT discussion. A 48-year-old man on May of 2009, prostate biopsy has been performed and histologically confirmed prostate adenocarcinoma, Gleason 7, first stage. And the patient had comorbidities, obesity, arterial hypertension, cardiopathy, diabetes mellitus, podagra. And hormonal radiation was prescribed and realized for this patient on 2009. Patient's condition suddenly worsened on September 2014, when suddenly appeared general weakness in the legs, coordination was affected, and urinary incontinence appeared. And was detected PSA elevation above 130. Radiological evaluation was performed for this patient, including spine MRI, chest, abdomen, pelvis CT scan, and multiple bone metastases were diagnosed with probably leptomeningeal involvement in thoracic 11, lumbar 2 vertebrae. And metastatic hormone-sensitive prostate cancer, high volume, was diagnosed. What treatment options for this patient? Maybe abiraterone, enzalutamide, maybe cabazitaxel, docetaxel, radium-223, or ADT.
So do you have some suggestions? What treatment option for this patient? Maybe Dr. Chasas?
Yeah, I see that, first of all, it's, I remember exactly, it's 7 years after primary diagnosis, yes?
Yes. Not 7, 5, excuse me, not 7, 5, yes.
5. Do you think it's need to perform additional biopsy for confirmation? Maybe we have some changes in this prostate cancer or neuroendocrine features or something like that, because it's progressed huge amount in metastasis. Maybe it's possible to use additional information for this case. But if a patient have a lot of comorbidities, but not especially for cardiac disease, I will prefer ADT.
Okay, thank you.
And what about opinion from National Cancer Institute, Dr. Petrauskas?
Yeah, so at this patient, ADT would be a good thought, but maybe some actual additional treatment options would be considered. So maybe I would go with a little bit more information about this patient. Sorry, he had leptomeningeal metastasis, right?
Yes, suspicious leptomeningeal metastasis.
And was a CT scan performed? CT scan for bones?
Unfortunately, and at this time in 2014, we didn't have a bone scan. At that time, bone scan was not performed for this patient because doctors concentrated to these conditions, and because he can't walk, he only sit in and can't walk, and the concentration was to the spinal metastasis. And
okay, so for this patient, I would definitely go with ADT, and because you said he had a lot of comorbidities, maybe I would avoid docetaxel at this time, and because we don't have any reimbursement for other medications, so only ADT for him, from my perspective.
thank you.
And as you said, this patient was symptomatic.
Yes, yes.
And maybe radiation therapy and palliative care for this patient would be an option.
Yes, yes, of course.
And what kind of radiation therapy? Maybe you have some suggestion, Dr. Bidrinskaitė?
Well, at this time, palliative radiation therapy, localized, probably should be offered, as radium-223 is not an option for this patient because it's still other options there are for systemic treatment.
So,
Let's continue.
Excuse me, I would like to ask, do you consider it neurosurgery consultation for this patient, because you told before that it was like bad patients when presented in National Cancer Institute, maybe need very quickly to send for neurological procedure, maybe need to evaluate it all laminectomy for compression cord, spinal cord, because sometimes radiation therapy at this moment it's not so works so quickly.
Maybe yes, thank you. Maybe radiologists have some comments because as conclusion from spine MRI, it didn't show compression of spine of vertebrae. That's maybe some comments from a radiologist about MRI and CT scan.
Would you maybe...
Unfortunately, we don't have the images of at this time point for MRI, so we can't make any comments on this. We don't have images.
Just the paper issues, yes?
Yes. The only conclusion that there were not spinal compression in this case.
If you don't have some questions, we will continue.
In this slide, I would like to remind the definitions: risk and volume, high and division and stratification of risk and volume in metastatic hormone sensitive prostate cancer. And as you see, patient belongs to high volume disease and probably a high risk if we think that leptomeningeal metastasis is visceral metastasis. And here is, this slide showed abiraterone efficacy in STAMPEDE trial and also Latitude trial proof abiraterone efficacy in comparing with ADT alone in prolongation of overall survival and in low risk and in high risk metastatic hormone-sensitive prostate cancer. And about docetaxel efficacy in and influence in overall survival in metastatic hormone-sensitive prostate cancer, and results based on almost 3,000 men, and were included several clinical trials, CHARTED, GETUG, STAMPEDE, docetaxel arm, and this meta-analysis showed about 10% absolute improvement in survival. Patients treated with docetaxel comparing with ADT alone, and that's two options. And here we see chronology of life-extending therapy, and we see that data from CHARTED and STAMPEDE docetaxel arm we got only on 2015 and 2016, and also novel antiandrogens results from STAMPEDE abiraterone arm, later enzalutamide trials in metastatic hormone sensitive prostate cancer came these results and data about efficacy of these medications later on 2017 and 2018. And I would like to remind that we treat this patient on 2014, and we had not data about docetaxel efficacy and about novel antiandrogens efficacy in metastatic hormone-sensitive prostate cancer. And for this patient, hormonotherapy was administered, triptorelin, bicalutamide, and zoledronic acid. And palliative radiotherapy was performed, and patient's condition dramatically became better, neurological symptoms and urinary incontinence decreased. Radiological evaluation, was performed on 2015 and on 2016. MRI scan, CT scans during hormonal treatment, and bone scan first time was performed on 2016 on March and revealed multiple bone metastases, minimally active. Here bone scintigraphy results, and we see that multiple metastases, but osteoblastic activity of the metastasis is minimal. Most of the sclerotic metastases seen on the CT scan are without activity, and we see good response to systemic therapy. But unfortunately, during hormonal treatment, we detected PSA increasing from 2.5 to 5.9 on the beginning of 2017. And at this moment, metastatic castrate-resistant prostate cancer was diagnosed. Here we can see beginning of 2017 elevation of PSA. And what to do now? question for discussion.
Sorry, what was his condition at this point?
Excellent. A COG 0. He is fully active, active in everyday his life and in professional, fully professional, active, very good status, performance status.
Maybe I would go with docetaxel. Of course, I would talk to the patient. What are his priorities? Would he agree to the chemo? But I would go with docetaxel at this point.
What is the doubling PSA time?
The doubling, we don't know, didn't calculate at this time. Only diagram. It's,
Could you show the diagram again for PSA dynamics? Okay. For me, docetaxel at this moment it's good option, and I hope it is this very good response rate, and in new possibilities later, additional treatment possibilities used. Docetaxel is my first.
This patient is in a good performance status, maybe abiraterone can be continued in this case? No?
Abiraterone, at this time, he was treated with ADT.
Only ADT,
Only.
yes.
And now elevation of PSA, and he became hormone resistant. That's question about first line treatment for hormone resistant disease at this moment.
Because
progression during ADT.
I showed that abiraterone was prescribed before.
No, because I have said because it was 2014 year we have no data about docetaxel efficacy in hormone sensitive status, and we have no data about abiraterone and enzalutamide efficacy. These drugs came later on 2015, 16, 17. That's why we treated patient at that time with ADT.
Okay.
And now it's beginning of 2017, and he became hormone resistant. And that's a question about first line for metastatic hormone resistant prostate cancer treatment.
Prostate resistant. It's for choosing for patients. It's possible all options, ADT in first line or chemotherapy. I will prefer maybe chemotherapy, docetaxel at this moment, but it doesn't matter. It's for choosing patients, tablets or chemo.
Can I say a few words? I don't know if you see me and hear me.
Yes.
See.
That is a very typical situation on our MDTs. I think that almost each MDT have such cases. That patient is asymptomatic, first of all. That's important. The next point, the ADT was lasting almost 6 or 5 years. It's really very good, long-lasting response. It means that
no, in hormone sensitive status only almost 3 years, because
it doesn't matter. But from the start of the disease, it's almost 5-6 years treatment,
but
with
intermittent,
radiation and the ADT.
intermittent.
Doesn't matter, but
okay,
it reflects
okay.
very good response for the hormonal manipulations. So still, I think that the biggest place for this patient is the hormonal manipulations. And 80% of our prescriptions here in Lithuania is a second step of hormonal manipulations. And do not use the like a bicalutamide or something like that, old-fashioned hormonal manipulations. They are not effective. At that point, we should use ABI, ENZA, or APA, what we have on the table. Today, we can use ENZA or ABI, or discuss chemotherapy. So we use such schedule that probably if the patient's fit enough, if his survival, predicting survival is good, so and the response to the previous ADT was also long-lasting, it means biologically more chronic disease. So for these patients, probably we prefer the next hormonal manipulations. And still, we are lacking very good and also therapies.
Sorry?
So in our MDT, we will discuss hemo or ENZA, and probably the abiraterone will be the choice.
Thank you.
That's my point.
Some more comments from auditory? No, so continue, please.
We have two suggestions: chemotherapy with docetaxel and antiandrogen abiraterone. And at 2017, abiraterone was we have reimbursed. And please take a look at NCCN guidelines, last edition, and for systemic treatment, not metastatic hormone-resistant prostate cancer, no prior docetaxel, no prior of novel hormonal therapy. Preferred regimes are abiraterone, docetaxel, and enzalutamide. And here are results from abiraterone study 302 that shows overall survival benefit of abiraterone comparing with ADT, and the benefit is 4.4 months. And also we know about chemotherapy. It's on 2004, well-known clinical trials, TAX 327, SWOG trials, prove that docetaxel is prolongs survival in first line of metastatic castrate-resistant prostate cancer. And our suggestion for this patient was docetaxel, but patient refused. And abiraterone with prednisolone was administered, and triptorelin, zoledronic acid continuing. On the June of 2020, adenocarcinoma of stomach for this patient was diagnosed, first stage, and on July of 2020, he undergoes operation, resectio ventriculi modo Bilrot 1, and adjuvant chemotherapy was not prescribed in this situation, and abiraterone, triptorelin, denosumab, because we have reimbursement of denosumab, that we changed zoledronic acid to denosumab, continuing. At the same, almost at the same time, on October of 2020, severe COVID-19 infection was diagnosed for him, and from October to November of 2020, patient was hospitalized due to fever, pneumonia, and respiratory failure, treated in the intensive care unit. Abiraterone was interrupted for a month. A radiological evaluation during abiraterone treatment on September 2021, chest, abdomen, pelvic CT scan was done and showed stable disease, and on September 2021 bone scan, conclusion was multiple bone mets. The dynamics are slightly negative. Two new metastases of low activity occurred, and negative PSA dynamic was observed from 2.8 to 18. And the patient underwent genetic counseling, and BRCA1 and BRCA2 were negative. Bone scintigraphy stable disease on 2020, and slightly progressive disease on 2021 September. And here is PSA dynamic, and we see that elevation of PSA was when AB was interrupted, and later PSA dropped again when abiraterone was reintroduced, and later PSA dynamics is negative. What next treatment options for this patient? And I would like to summarize that a patient with high volume metastatic prostate cancer disease is alive for 8 years, and almost 3 years of ADT, later treatment with abiraterone. Also, he experienced carcinoma of ventricle operated, and also severe COVID infection. And at this moment, his ECOG status is 0. He is fully active and professionally active, and but the disease is slowly but progressing. And also, I would like to remind that he wants to avoid chemotherapy. And I would like advices what to do for next treatment.
So if I can speak, Alexander here. So it's nice to see that patients received androgen, next generation androgens, and didn't progress for more than 3 years, as I see.
5 years.
Professor Yeltas, 5 years, sorry. So it's, I think the Professor Yeltas was actually right when he said that we should exploit all hormonal manipulation possibilities, because he was right in this case. So, but afterwards, the hormonal therapy, I think it's time for the chemo after all. So, docetaxel again. And I think because there's lack of information that if we change, for example, one hormonal therapy from abiraterone to enzalutamide, there will be no overall benefit in overall survival. So I think he should be given docetaxel.
I would like to ask you, what does it mean his disease is slightly progressing? We should have from radiologists very clear answer if they think that is radiologically progressed or no, because as I understand, the patient still is asymptomatic with good performance status, blah, blah. So at that point, it's very important to point out when to start. When his condition worsening, according to the clinical trials, we should start with radiological progression. That is prostate cancer working group 2. There is very clear criteria when we should point that is radiological progression. That is the right point, because the patient is still asymptomatic. I am not sure that at the moment, probably we can continue 1 or 2 or 3 months with AB, get improvements that new metastases appear, and then start To my knowledge, 2 new metastases on bone scan is not a progressive disease.
Let's ask radiologist.
We don't hear you, Dr. Tiškevičius.
We don't hear.
Working group 3, we should have 2 or more mets on the second scan to confirm the progression. Or if we, for example, have the next scan and we see the only 1 metastasis, we should perform the next scan after several months, for example, 2 or 3 months, and then we look for 1 more metastasis. So at this scan, it was very present 2 metastases, as I remember, if I remember correctly. So we can, according to the scintigraphy, we can state that it is a progression, because we deal with castration-resistant prostate cancer. So it is like in working group 3 recommendation. So we have 2 metastases.
Yes,
I would like to ask
and I should
radiologist
stress,
about.
I would like to stress out that if the radiologist state very clearly that that is a signs of progression, it means that according to our national laws, according to our National Ministry of Health laws, we can't continue with abiraterone.
I would like to ask because a little bit don't understand. SPECT scan or bone scan was performed, but computer tomography was performed too, yeah?
Yes, it was, but
exactly.
on CT there was no progression, just in bones. So
Okay.
we have to rely on scintigraphy in this case, not CT.
Maybe we should correct 2 images modalities like CT scan and bone scan together and discuss. It's sometimes sclerotic lesions. It's not possible to exactly to say that it's progression or something like that, new sclerotic lesion in CT. But bone scanning is more metabolic activity and it can be. But in this case, we need to receive correct answer from a radiologist. Like Professor Mindaugas said, it's because it belongs reimbursement, and then we can't continue the same treatment if bone scan specialist said this is progression. Sometimes we discuss about last decision after bone scan, but sometimes we need to, of course, know what is the correct and true situation. Last day, yesterday, was published one interesting paper which was presented in ASCO GU a few days ago about enzalutamide treatment in first line, and after progression continue the same treatment if not rapidly a big progression on bone scan, and showed that additional benefit was found in PFS, progression-free survival, if you stop and another treatment go, or maybe continue the same treatment modality. It's very interesting paper. Of course, it's not very big trial that was presented in ASCO GU. You can see it's interesting, and I think we need to very close discussion with radiologists, nuclear specialist radiologists, and for completed discussion and decision.
But international.
Progression in radiology, it's not so simple. It's all those criteria are for clinical trials, and in clinical practice, sometimes it's a little bit different. So we have to communicate each with other, and then we have to give one answer together, not only radiological answer.
Totally agree, Ruta. It's very good. Correct.
And about novel anti-androgens, sequencing of androgens, abiraterone, enzalutamide, or enzalutamide abiraterone is not recommended in international guidelines, and the recommendation is to avoid the sequencing if it is possible.
Maybe Sigitas available to comment or not? Because previous speech we didn't hear.
No. Hello, can you hear me?
Yes, we hear.
Hello. Yes, so the comments from my colleague Renata was correct. So if we wanted to confirm progression on bone scan, we have to have 2 consecutive scans. And on the first scan, if we see 2 new metastases, we have to confirm this on the next scan. So the criteria is are defined in this prostate cancer working group and is 2 + 2. 2 new metastases on consecutive scan. Yeah.
Thank you. Maybe Nick?
Yeah.
Okay, thank you. We are planning to repeat the bone scan for this patient, and but the question is if progression was confirmed, in what to do for what treatment option next for this patient could be. And I would like to remind that patient preferred to avoid chemotherapy. He doesn't want to be treated with chemotherapy. And my question is, and what about radium-223 for this patient? Because it's option, and it's proven that this drug is pharmaceuticals, radiopharmaceuticals, is prolonging overall survival, and patient has disease only in bones without visceral metastasis, but he is asymptomatic. What do you think about this option? If progression was confirmed, will be confirmed?
If progression is confirmed after repeated CT scan and bone scan, because it's almost half a year since those CT scan and bone scan, if I count well, then we need to know if it's only in bone progression, or maybe there are lymph nodes or something else in CT scan. And if it's only in bones, then radium-223 I would suggest only if the patient absolutely does not want chemotherapy or other systemic treatment, because it's like second line would be.
Sure. More comments?
I suggest discuss with patient about possibilities chemotherapy, because I don't know, 60 years old man, good condition, COG 0. We need to discuss and explain that chemotherapy can produce more 1 or years additional benefit if we use in this setting. For radium-223, I will be little bit confused, because it works very good for symptomatic patients. And how we should check efficacy for these patients. A little bit, because main endpoint for this treatment, it's not only overall survival additional benefit, but in alkaline phosphatase decreasing, not PSA, LDH, and symptomatic pain reduced. But this moment we have very good condition for patient, asymptomatic. I think we need to more discuss with patient about possibilities chemotherapy. It's very good tolerated, docetaxel. I don't know why this patient is so afraid.
Okay. Thank you, Alvydas. I absolutely agree with you. And we have had a hard talk with this patient about chemo, but he refused once to be treated with chemotherapy, and his point of view is such. I don't know. I will try to talk again about chemotherapy with him.
Just the suggestion probably how to handle this situation in terms of explaining the patient for the chemotherapy. Well, we agree this is the progression and we need the chemotherapy. And for the patient, probably the best, the patient comes to the multidisciplinary union, and many specialists explain the situation, what are the options, chemotherapy, radium, 223, and the patient well listens to the opinions of all the experts for the treatment. That probably should work. And if not,
yes, but during a pandemic situation,
no,
we
just to present with the results of the multidisciplinary union, results of the discussion, and another option is second opinion to propose.
We don't invite patients to contact with multidisciplinary team. No, without patients, we make decisions MDT without patients. And no, I will try. I will try to explain again about chemo.
To make the conclusion in written, and then he also can ask the second opinion in other centers. That's how it's done.
Yes.
If somebody
yes, but
has doubts, well, if you just
yes, I fully agree. But patient they has right to refuse from our suggestions. Yes.
Yes, can I make a notice? My also idea, probably we can wait a little bit because the patient is progressing, but not so rapidly. And his psychological problems might be due to the fact that he has no symptoms. If we wait, let's say 2-3 months, more blastic lesions go to the clastic stage, and probably some symptoms appear. In such circumstances, typically patients are more sticking to the recommendations of the doctors. Also, you can use to send him for another one opinion to another one chemotherapist. Probably he will psychologically find the way how to prove him, how to convince him that he is going to benefit from chemotherapy. Typically, in my hands also, the patients who are asymptomatic, they are typically wanted to refuse idea of chemotherapy. But when they feel pains, they talk in different way. So another one way, just wait 2 or 3 months. And I agree with Alvidas. I was talking a few times with the Dr. Parker. He's a father of the trial, Alsimka trial. I should stress out that radium-223 was established just for palliative symptomatic therapy. They incidentally find that there is better survival. Actually, the drug was developed just to diminish pain, not to prolong survival. Of course, it might a little bit prolong survival, but typically what in the trial they use more terminal patients with more disease, more rapid disease. So I think that in such stage, we have no evidence that radium-223 might help something. It's better to reserve it. Probably later we will use it. At the moment, we should do much.
Thank you, Professor. I agree with you, and I think that every decision is making for recent patient. And individual decision on this patient will be made maybe later?
Yes, yes. Our plan is to repeat the bone scan. No. And also PSA, and then to make decision together with patient.
But today we make decision to wait for bone scan. Thanks for MDT.
Okay.
Just I would like to ask the radiologist, what do you think about whole body MRI?
In this case, we have to do bone scintigraphy as before was done bone scintigraphy. So we have to compare the same modalities.
Okay.
Thank you. Maybe you have some comments.
And what about radium-223 and bone scintigraphy scans? So as mentioned, Professor Javaltas, that we have in the same metastasis, we have also blastic osteoclastic components. So of course, radium-223 works only on osteoblastic components. So there are present some MRCP castration-resistant patients who has prostate cancer metastasis with more dominant clastic component. So it is, I think that bone scintigraphy could answer if we would have at least very less effect on this metastasis. Because if it is dominating of clastic components, so radium-223 doesn't work at all because of the physical activity and uptake in the bones. And also I noticed that radium-223, it is not evidence-based data, only from my own clinical opinion. Radium-223 is working more in really high uptake lesions. And if we have a very tiny uptake somewhere after radium-223 therapy cycle, we have the increased uptake in those lesions who were more like more like less osteoblastic. Yes, so the main radium-223 dose comes to the more uptake has lesion, the more radium-223 goes there. So it is because of the uptake mechanism just in bones. So of course, if we have only 2 progressive lesions, but the rest of the lesions is quite on low uptake, so I think that radium-223 will not work in the old lesions, only new ones, for example. So it's just my own opinion.
Only a short remark. As we know, Alsimka was confirmed the primary endpoint, but later, as you know, changed guideline because Alsimka trial and radium-223 was pushed back to in late stages of treatment. Earlier, its radium-223 was confirmed in the first line, in second line, in third line, and all patients, symptomatic or asymptomatic. But at this moment, recommendation, and Guy said, it's symptomatic, metastatic, resistant prostate cancer with before used some therapies like ADT, ARTA, or chemotherapy.
Thank you. Comments?
Thank you. Thank you for the discussion. It is very useful for me. Thank you.
For the presentation.
And we will start the next case discussion, please.
Good afternoon, dear colleagues. I am Saulius Mikėnas. Today I'm going to present a case report about non-metastatic castration-resistant prostate cancer. So, for 50 years old patient, was found that the PSA was 4.25. Also, it was transrectal ultrasound made, and it was without any abnormalities. So the doctors did 6-course random transrectal ultrasound guided biopsy, and the histology showed that the patient was sick on prostate adenocarcinoma, Gleason 7, 3+4. 2 cores of 6 were positive for cancer. So the first multidisciplinary team meeting was arranged, and it was decided that the best treatment option will be hormonal and combined hormonal and radiotherapy, beginning with low prorenin, 3.75 milligrams, and also cyproterone acetate, 50 milligrams. So you see a graphical visualization. We started hormone therapy when the PSA was 7.44, and then the PSA fastly decreased, and it was quite stable. And when the time came for the planned radiotherapy, the patient refused of this treatment option and expressed wish for the operation. So in 2008, the radical prostatectomy with lymphadenectomy was made for the patient, and histology results showed poorly differentiated prostate adenocarcinoma, Gleason 3+4, reactive lymphadenopathy, and perineural invasion. Here you see the, once again, graphical visualization. You see that we made operation when the PSA was 0.3, then the PSA decreased to 0.01, and then it started slightly to increase. When the PSA was 0.278, it was biochemical progression of disease. So the second multidisciplinary team meeting was arranged, and it was decided that perhaps the best option for the treatment would be hormone therapy, beginning with triptorelin for 6 months and biculotamide for 1 month. And also it was necessary, according to the doctors, to prescribe salvage radiotherapy. So the patient got external beam radiotherapy to the prostate field, and the total doses was 66 grays. The only side effect which patient experienced during the external beam radiotherapy was dysuria. So from here comes my first question for discussion. Was it really necessary after biochemical progression of the disease to start combined hormone and salvage radiotherapy? Perhaps would have been enough only to give a salvage radiotherapy? So I didn't give any possible answers, but I think we can decide on our own. So colleagues, what are your thoughts about this case?
So I call for discussion, please. Maybe Professor Ievaldas has opinion.
Not easy question, because we have no very good evidence-based data on that. Yes, there is some mainly retrospective few trials which try to prove that the combination salvage with the hormonal therapies provide better results. But as I said, the evidences are very weak. And in our recommendations, there is no very clear answer. Should we use the with N plus disease? It's more clear, because N1 disease have shown some improvement with hormonal therapy. But here, as I understand, the lymph nodes are negative. There is no clear where there is local recurrence, probably local recurrence, because the PSA recurrence appeared 2.5 years after the surgery, as I understand. Yes, so clinically it's telling that it's not metastatic. Probably it's recurrent, locally recurrent disease. So, according to our national law, our national health ministry law, we should use only salvage radiation. But experimentally, yes, we can use, but in such case also we should use it probably 6 months, no longer. Because still we are using just local therapy, and aim is to try to stop disease without any hormonal manipulations, long lasting in the distance. We should reserve the ADT for the future, because these patients obviously will recur in the future. So I can't provide you very clear answer. Some data exists that might hormones help, but it's off-label data, and according to our national ministry law, it's also off-label.
Thank you for your comment. Maybe more comments?
I would like a short comment. I totally agree with Professor Mindaugas, because PCA level, it's low, and it's what is mean? It's mean that metastatic disease, it's maybe it's not present at this moment, but locally we can check. Maybe MRI shows some changes in the prostate area, and if showed that it's possible to recurrence in this area, we will start radiotherapy only, without any ADT, because we can check PCI level. If we shoot to exactly place, we can reduce and decrease PCI level without any ADT. And maybe I will preserve ADT for later stage or later lines.
My actually question for morphologists: what do you think Gleason 3+4 after hormonal therapy? Do you think it's right evaluation? Probably it might influence your decisions.
Yeah, for sure. Of course, we don't have any information at the diagnosis what patient was under some treatment, so the classification according to Gleason was applied. But still, the tumor don't show any any signs of treatment effects. So looks like I think it's correct. It's correct. But still some comment and question for presenter. Could we come back to diagnosis at radical prostatectomy?
Okay, sure.
Yeah, one comment. Tumor is not poorly differentiated. Tumor was the diagnosis was tumor. It was old description of a tumor, but it was missing one word. Tumor was categorized as medium to poorly differentiated, not poorly differentiated.
And status of the margins is not clear.
Yes, the margins was clear from tumor, so it's radical resection.
I would like to our group ask one question, because this patient received ADT before radiotherapy, planning radiotherapy. What is opinion about that ADT before surgery? Because it's very interesting data that it's no efficacy and a little bit worse later some results. Maybe Professor Mindaugas can shortly comment.
Yes, in previous years, we have few trials which show that neoadjuvant hormonal therapy before prostatectomy have no any influence on survival data. It caused few morphological responses, probably few metastases, find few metastases in lymph nodes, but that have no influence on survival. And because of these and old trials, there is a statement that we should not use any hormonal therapies before surgery. But at the moment, the era of hormonal therapy is changed. We have a lot of new hormonal active substances. And I should stress out that especially in USA, ongoing 5 or 6 very big trials, which would like once again to look to the modern hormonal therapy when they use maximal androgen deprivation, but using not the bicalutamide, but let's say abiraterone or enzalutamide together with ADT before the surgery. And this modern hormonal therapy, if it's act, nobody knows. We should wait a little bit. There will be new data, I think, in the coming few years. We will have very new, interesting trials and data, especially few institutes are working in that field. Also, there is investigations together with neoadjuvant chemotherapy before the radical prostatectomy. Also, this field is open. And also, as I know, few trials are recruiting patients. So who knows? But according to the today guidelines, there is no place for ADT before surgery. That particular case is because the patient changed his mind and idea about radiotherapy. In our clinic, we also have few patients with such scenarios. We as a clinicians, we should stick to the patient opinion, and sometimes we change the strategy. So that's a real life. But according to the rules, we shouldn't use ADT before the radical prostatectomy because it's not have impact on survival.
Thank you. Maybe more comments?
We know, so let's move on. So the next graphical visualization shows you that after hormone therapy and after external beam radiotherapy, the PSA decreased to 0.021 and then again slightly reached 0.2. I wrote biochemical progression of disease in brackets, And from here comes my second question for discussion. What PSA level should be considered as a biochemical progression of disease after operation and after salvage radiotherapy? Because we know that after operation, when the PSA is higher than 0.2, it's a biochemical progression of disease, and after radiotherapy, when the PSA is higher than nadir plus 2 nanograms per milliliter, then it's also a biochemical disease progression. But what about when they are both made for the patient? What are your thoughts about this?
Maybe somebody have an opinion?
Do we have in the group radiotherapist?
Have some group?
As I know, the description is telling that we should have 2 PSA increasements after the nadir. So you have nadir was after the salvage therapy, you reach nadir, and after that 2 increasements, that is a biochemical recurrence. And from my point of view, that is very good case to do the PET PSMA investigation. But at the 2011, as I remember, such investigation was not available, not only in USA, but in Europe as well. So at that time, probably should do the just MRI investigation.
We need to check PSA double time. How long
Yes.
its period was.
Yes,
because 0.02 and now 0.2. It's 5 times higher than nadir, but we need to check time. If more than 9 or 10 months, it's no need so very carefully to look. But in this day, we will send patient for PET PSMA for detection, because bone scan or SPECT CT scan didn't show any changes because it's too small PSA. I hope. I think that.
You?
Okay, great. So let's move forward. So due to this biochemical progression of disease, a surgical castration was offered for the patient, but he refused of this treatment option. So it was third MDT arranged, and it was decided to renew hormone therapy, triptorelin 3.75 milligrams injections every 4 weeks continuously, and also bicalutamide 50 milligrams for 1 month. From 2011 till 2016, disease was stable. PSA was not higher than 0.1 nanograms per milliliter. Patient got hormone therapy. In 2016, disease started to progress. PSA started to increase. Several times the doctors offered for the patient surgical castration, but he refused of this treatment. So the maximal androgen blockage was prescribed with triptorelin and bicalutamide. So my third question would be, what are your thoughts about continuous and intermittent hormone therapy in this case? Because when the patient's PSA was stable from 2011 till 2016, and he got hormone therapy continuously, maybe it would be rational to give intermittent hormone therapy, for example, to make a break for several months. What are your thoughts about that?
Did you test testosterone level?
No, at that moment I haven't found any data about testosterone level.
Okay. After, let's say, in a hormone-sensitive setting without metastasis, treatment might be continuous or intermittent. Especially, let's say, 10 years ago, when a few trials with intermittent hormonal therapy appears, we were waiting for the results, and the suspicion was that and ideas was that probably intermittent schemes will prolong the so-called hormonal sensitive setting in any way, but it prolonged. There was such idea. And also there was idea that probably it might cause less side effects. But at the moment, we already know, and especially for metastatic patients, that intermittent therapy do not cause longer hormone-sensitive period. No, the same period in both groups. So the first target they miss. They do not prove that. And also with hormonal therapy according to the quality of life. In these interrupted periods, patients anyway experience all side effects like osteoporosis, cardiovascular risk, metabolic changes, hot flashes, blah, blah, blah. So all these trials do not reach their primary targets. So it not prolong the hormone sensitive period and also do not cause better quality of life. So at the moment, urologists think that intermittent do not work. And actually, especially for metastatic settings, there is suggestion not to use intermittent. So, but this patient have no metastasis. So probably for him, we can try to use this intermittent. Probably we will spare some budget for medical insurance company, but it's not clear if we will benefit for the patient with prolonging his hormone sensitivity. It's unclear. But yes, such scheme exists. That is illegal with not very clear evidences of clinical benefits. So my opinion, at the moment, I try not to use the interruptions in the treatment. In previous years, I liked the idea, but as I said 3 years ago in consensus conference data from Anderson Cancer Institute, they show very elegantly that there is no effectiveness of this therapy. And Professor Hussein, she was very big proponent of this idea. She says that they also stopped this idea and they do not use intermittent schemes in the treatment. Such a tendency today.
Okay. Thank you. Maybe some more opinions.
Okay, so let's continue. So in this slide, you see PSA dynamics from 2016. You see how slowly and steadily the PSA increased. When the PSA was 3.7, we made a CT scan. There were no signs of disease progression. We also made bone scan, and there was a focal structure in the left pubic bone which was considered as a possible metastasis. In other bones, there were no typical signs of metastasis. So during the fourth multidisciplinary team decision, it was decided to make a pelvis MRI in order to confirm those metastases, possibly metastases which were seen in bone scan. And if these metastases would have been confirmed, then prescribe abiraterone. Luckily for the patient, there were no pathological structures in the site of the prostate. When we made pelvis MRI, there was a small focal structure on the right near dorsal wall of urethra, but it was too small to differentiate. We checked the PSA level and it was 12.6, when the previous one 7.556. So again, a graphical visualization for you in order to better understand how the PSA was changing. The next, what we did, after 3 months, we repeated pelvis MRI, and the results were the same, no pathological structures in the site of the prostate. There was the same focal structure on the right near dorsal wall of urethra, and it was without negative dynamics. Once again, we checked PSA, and it was again higher, 14.4. The patient was on hormone therapy. Once again, also we repeated bone scintigraphy, and in comparison with the previous bone scan, there was no negative dynamics seen, and there was the same remaining size focal structure in the left side of pubis, and it was considered as a possible metastasis. In other bones, there were no other typical signs of metastasis.
Excuse me, can I interrupt shortly? I would like to ask radiologist, is MRI the main modalities for testing bone metastasis? If bone scan show that it's possible metastasis, maybe need to test by CT.
This is the case when whole body MRI would be really good choice, because on MR images we can see some structures, some lesions earlier, about 3 months when on bone scan. So this is a really good indication for whole body MRI. And especially if we have PSA not more than 100, so less than 100, and also if it's less than 50, so it's even more important to do. It's more it's better to do whole body MRI, not scintigraphy. And MR images are really good for detecting bone metastasis.
And I would like to ask maybe Dr. Komiagenia, if MRI would be uninformative, what PET-CT would you recommend in this case?
So of course, MRI is counted as a gold standard for bones in radiology. And of course, if we have on bone SPECT or bone scan imaging as a suspicious lesion, so we can perform also whole body MRI to check the whole body, because it covers the total body, even total, not whole body. Or also a localized MRI just to check is it lesion right or no. But if we have a PSA range as high as 13, so of course it could be more metastasis than this one suspicion lesions. And about PET-CT, of course, as it was shown by radiological presentation, it is totally useful everywhere, I think, and at every point, even when conventional imaging is negative. So at so high rates of 13 PSA, we can perform, according to the indication, also Holline. We can try to perform Holline, but I will not recommend it, of course, because we had a case when we had 12 PSA, and we hadn't found nothing on Holline PET-CT. So it is like more a history for prostate cancer investigation. So PSMA targets are those what we need to use if we plan PET-CT.
Thank you. I have a question. Do we have a hormonal resistant disease now?
Well, I will speak later about, so I don't want to spoil the whole story. Okay, so let's move on. I think, so during the 5th multidisciplinary decision meeting, the doctors decided to continue hormone therapy and to repeat body MRI again and bone scan after 3 months. After 2 months, we did the body MRI, and the results were the same. There were no signs of possible metastasis in the left pubic bone, which was seen on bone scan, and no signs of disease progression at all. So we also repeated bone scan, and the results were the same as in the previous bone scan. Compared with the previous one, there were no typical signs of metastasis. We also checked the PSA, it was 18.6. Once again, graphical visualization to better understand the case. And it was 6 multidisciplinary meeting arranged, and it was finally determined to check testosterone level and to continue surveillance. The testosterone level was okay, it was at castration level. The PSA was even more higher, 26.7, when the previous was 18.6. So we also continue to repeat bone scans, and in comparison with the previous one, there was no signs of disease progression, and it was the same size remaining unchanged focal structure in the left side of pubis. But what was new, it was suspicious para-iliac space lymph nodes, 12 millimeters in size, but it was no signs of that they might be metastatic. So in 2018, patient's condition was quite stable. He had no complaints. Once again, we offered him surgical castration, but he refused of this treatment. The triptorelin was ongoing, but the dosage was higher, 12.25 milligrams, injections every 12 weeks. Once again, we checked after 2 months the PSA level, and it reached the highest point, 33.16. The testosterone level was okay, and we made also abdomen and pelvis CT, and appeared 2 small lymph nodes along common iliac vessels. Yeah, so this is the slide which illustrates the PSA kinetics from 2016 till 2018 with all our actions, all our imaging modalities which we made in order not to miss something. And it is important to mention that all these modalities were negative without any signs of disease progression. So at the end of 2018, our urologists have met again and decided, once again decided that the diagnosis is castration-resistant non-metastatic prostate cancer. And at that time in Lithuania was an opportunity to enroll patients to apalutamide program, and this patient met all the enrollment requirements. His PSA double time was 6.6 months. So at the end of 2018, patient started treatment with apalutamide, 60 milligrams, 4 tablets daily, continuously. Also triptorelin was ongoing every 12 weeks. And this slide shows you the PSA dynamics from the beginning of the treatment with apalutamide. You see how fast PSA decreased and how stable it was till 2021. We also made 2 times CT scan and bone scan, and in order not to miss something, and the conclusions were that there is no metastasis, no signs of metastasis. And here I have also a question for discussion. How often we should do imaging modalities when PSA is stable? What are your thoughts about that?
Maybe somebody wants to comment? Maybe Professor?
I would suggest once a year.
Great, okay.
If PSA is stable.
Okay.
Everybody agree?
Of course, we don't have clearly a recommendation how to deal with patients, hormone resistant, hormone naive, or castration resistant patients. Of course, every time when you have a new clinical signs, I think, every time when the physical state is changing in your patient, and if we have PSA stable without any differences in the health of our patients, I think that it is enough to perform once a year. Maybe for castration-resistant patients would be 6 months, for example. But it also, of course, depends on the comorbidities also and the state, patient physical state.
Thank you.
Okay, thank you then. So, like I said, in 2021, the PSA started to elevate again. So we made body CT. There was no evidence of metastasis, only right external iliac lymph node, which was 9 millimeters in size. Previously, it was 12 millimeters in size. Bone scan was in comparison with the previous one, was without any signs of metastasis in bones. And the last slide with the graphical visualizations, which clearly illustrates you how steadily and PSA decreased and how stable it was. Also, you see that we repeated CT scan and bone scan 3 times, and we also made testosterone level at the end of 2021, and it was at castration level. And also it is important to mention that now the CT scan and bone scan are planned for this patient at the end of February. He will come to our hospital. We will make these imaging modalities in order not to miss the radiological disease progression. And I have last 2 questions for discussion. So if planned imaging modalities which we will make at the end of February won't show any metastasis, should we continue apalutamide? Because the PSA is slowly but steadily rising. The last one, PSC, I don't know if you saw, is 6.6, which was made 3 weeks ago. So that's the question. Should we continue apalutamide, or if not, then what are the possible other treatment options? And the last question would be, are CT scan and bone scan the right imaging modalities that we should rely on when making decisions? I mean, maybe we should rely on other imaging modalities when these imaging modalities do not show any disease progression, and when we make them several times in a row. So, okay, what are your thoughts? Please feel free to share them.
2 different questions. Maybe first question would be available from medical oncologist, Dr. Chasas, maybe.
Yeah, it's the same situation like previous case report. If we have patient with hormonal sensitive and castrate-resistant non-metastatic disease, apalutamide at this moment it's the best possibility, best opportunity. But if we have metastasis, of course we need to change to another ARTA, like ABI or enzyme. It's a little bit strange, because it's new one generation, we change another old generation. I think if we will find the metastasis, I will choose the first line castrate-resistant metastatic prostate cancer chemotherapy with docetaxel.
Thank you. Maybe more comments due to this question, please.
My question, not a question, but comment is the presenter is asking what we should rely on. So not only on the radiology, but also on the symptoms. My answer, so never forget, the symptoms also is the driver of our decisions making. But of course, the conventional imaging, it means the CT and bone scan. Everyone wanted to do the PET PSMA, but please remember the PET PSMA investigation is very expensive. At the moment in Lithuania, not available and not reimbursed. And financial toxicities, let's say, in these patients are high enough without any additional radiological super investigations. So at the moment, according to the guidelines, we should stick to the CT and bone scan or MRI, and then to do the decision. If there is no radiological progression, no symptomatic progression, just continue with APA. And also as I interested, typically when we are switching to another one hormonal therapy, the response rate is very low, approximately 25% of patients responding to the next hormone. And the response period also is very important. Typically it is very short, 3-6 months, no more. So typically what I'm recommending in MDT is just switching to another biologically active therapy. It means chemo, typically. Of course, sometimes the patients can't get the chemo. Sometimes he's refusing. Different scenarios are. but it seems that scheduling should be from hormonal therapies to chemotherapy. But after we have the evidence of radiological progression.
Thank you. And
I would like to comment the second question about imaging, what we should rely on, what imaging. So I think that nowadays we should rely for distant metastasis. We should rely on PET or SPECT PSMA, but of course it depends on availability. And if we are suspecting local recurrence, so we should rely on MR imaging. And if we don't have availability for PSMA, PET or SPECT, so we have to do CT or bone scan. Maybe my colleagues have some.
I have comments, not only for the Dr. Grigene, but also especially for nuclear doctors. When you will do all your jobs to introduce that investigation, PET PSMA in Lithuania, what we are lacking, why we are waiting? We have now the possibilities to produce this drug. Where are the reasons? Why?
Mm-hmm. There are especially difficulties in legislation of this drug, because here in Lithuania we have no permission to use PSMA even at the trial base. Of course, to have it for a trial, we need to find money from somewhere. So
yes,
we
know,
would be only permitted.
But what is interesting that Poles, Latvians, even Estonians, they can use, but we are Lithuanians like gods, we can't use because the MA do not permit that. But
so yes,
what we're using Estonians or Latvians?
The problem is, of course, cyclotron, because if we sign to the kind of project on PSMA trials, we can't produce and we can assure quality control. We only can deliver from the other sites, and with gallium it wouldn't be possible, and fluorine PSMA could be possible to get from Finland, I think, in 2 hours flight. But still, we cannot assure the quality for a trial. And of course, there is no interest of Lithuania in this company of trials, because we are too expensive to them. So other countries just, I think that they created projects and they have involved to the trials, so they have an opportunity. And beside that, of course, beside the synthesis, they can afford their patients, or they can just prefer their patients to do it on the commercial basis, yes, beside this. So they have permission to synthesize this molecule and also to use this molecule as a trial center. So we have no permission even to deliver this molecule to us from our Lithuanian legislation problems. So it is. And of course, the second step would be the reimbursement of these projects and trials. So according to this case, everyone wants PET, of course, but we should think, would it change our treatment decisions or not? Yes, maybe we should perform it if we feel like we want to.
Yes, but let's say lutetium is coming. It's very close to us. If we are not going to use PET PSMA, lutetium will be not for us. For Estonians, for Latvians, yes, but not for Lithuanians, because we are, I don't know, probably too retarded.
So for us nuclear medicine physicians here in Lithuania, it is a very vulnerable topic because of course we try to change something, but of course we we stepped to the wall because of the money, because of the expenses on the health situation.
Urologists are ready to help you, okay? We should unite our efforts, forces. I think that oncologists also do that. Not probably.
Yeah, I would like
but also they have their interest there also.
Yeah, we working very close with Donatas Vajauskas, and Liutecijus is coming at this moment for only clinical trial, but situation is terrible. Latvian and Estonian colleagues, Poland, since many times ago started lutetium, PSMA, FDG. Of course, it's old-fashioned, but use many other tracers. We in Lithuania, please ask us, Professor Jevaltas, medical oncology community, we can push, because at this moment we need money. We have in our country a lot. It doesn't matter, pandemic or not. But in this situation, especially oncology, and now when we start thinking and working with program oncology beating cancer plan, we need to push very fast. And at this moment, we can include all possibilities, all equipment. But we please don't sleep. At this moment, we need to collaborate between all nuclear specialists together. Please come together, urologists, medical oncologists, radiologists, and all together we can fix this problem.
And also patients organizations. I think that with PET investigations are interested not only prostate cancer patients, but other oncological associations also. So we should unite our efforts to do that, because it seems that the future is PET PSMA investigation. I don't know if it will change a lot our strategy, but who knows? Who knows?
So please believe me, we don't sleep at all, but the discussion is very difficult with our legislation authorities. So of course, the conversation lasts a very long time, and COVID situation, of course, interrupted this all discussion with our health ministry. So now we try to discuss again and again. So we will keep in mind that you are on our side. Thank you.
We can help. Please ask and wait.
Thank you for all us. Maybe we can finish this case report.
Yeah, so it was a really interesting discussion, so thank you for all of you.
Yes, and I will invite the third one, yes? Is this available? Yes, we are waiting. The third one, case representative, please.
Yes. Good afternoon. I am a resident doctor in medical oncology, and today I would like to present a clinical case of oligometastatic prostate cancer. Actually, this case was previously discussed in the last year EBU session, so I'm going to concentrate on the further investigation and treatment. To begin with, patient was 56 years old. He was first diagnosed in March 2019 with initial PSA level 33. And digital rectal exam revealed tumor classified as T3. Initial TNM was T3 and 1 MO. And PSMA PET scan revealed pathological accumulation not only in prostate, but also in the external iliac and obturator lymph nodes of the right pelvic. para-aortic space, and right lung root. It was considered as metastasis. And pathological exam confirmed that it was poorly differentiated adenocarcinoma, Gleason score 4+5. In addition, patient underwent laparoscopic lymphadenectomy of the right iliac area, and histology revealed prostate carcinoma metastasis. Gleason score implied was 5+4. Since July 2019, therapy was begun with hormonal therapy with bicalutamide and triptorelin, which was continued, and PSA dropped from 36 to 5.85 nanograms per milliliter. And since October 2019, early chemotherapy was given to a patient, docetaxel 6 courses. After the courses, PSA was 2.14. PSMA PET-CT was repeated in March 2020. It showed positive dynamics as compared to previous PET-CT, and the PSMA expressing malignant process remains only in the right lobe of the prostate. Elsewhere in the body was no lesions found. Also, there was a lymphocell by the right pelvis wall, which was drained. Excuse me. Since April 2020, it was decided to perform hypofraction radiotherapy to the seminal vesicles, both with hormonal therapy and enzalutamide, for 3 months. Patient was consulted for a second opinion of a consultant in Norway. After treatment, PSA levels dropped from 1.73 to 0.78. Body MRI repeated in August 2020 shows some suspicious signals in the prostate, otherwise stable disease. Also, patient was repeatedly consulted of a doctor in Norway, and it was agreed on therapy with bicalutamide and continuing triptorelin. Also, preventive radiation therapy to both breasts was given to prevent gynecomastia. And here in this graph, you can see PSA levels dynamics, and it shows PSA levels of 2 years of treatment. In June 2021, PSMA PET-CT was repeated, and it showed localized lesion in the prostate. Unfortunately, due to the technical issues, we cannot show the images because it was performed abroad, and we didn't have the data at this moment. Patient was pre-existent symptoms was mild urinary obstruction, so it was made a diagnosis update that it is a PSMA with local relapse of pre-irradiated prostate cancer without detection of metastatic disease. Actual PSA was 0.36. And my question to MDT would be, what would be your suggestions for such a patient?
would like to make a comment concerning this patient before answering the questions. I follow the patient from the beginning when I administered chemotherapy, and the patient is also followed by radio-oncologist radiotherapist in Norway. It was mentioned, and the follow-up is continued in accordance with the doctors in Norway. The patient is asking second opinion, so the decisions are mutual. Always we keep in contact with the doctors from Norway. So, well, the question is now local treatment or hormonal therapy. The patient is now on hormonal therapy, triptorelin and bicalutamide, 150 milligrams a day. That why was the irradiation of the breasts made, and well, so the question is what the treatment further for the focus for the lesion in the prostate.
Maybe
The opinions.
maybe Professor Yeltas, he has a point of view about local treatment for prostate.
Just a little explanation. Also, the radiochemotherapy with enzalutamide also was proposed by Norwegian doctors, and the patient had this treatment, and well, still the lesion exists now on the last test in June. Okay.
Radiation
Sorry,
therapy. Okay.
Can I clarify? So patient has a localized disease. He received docetaxel and radiotherapy, right?
Now at the
And now he's
beginning.
receiving ADT.
At the beginning of the PSMA test, there were lymph nodes and pelvic lymph nodes, and also suspicion of the lymph node in the mediastinum. That was suspicious of metastatic disease.
I may demonstrate the PSMA SPECT images, please. Can we share the screen? Yeah, can you see the images?
Or the PET-CT scan is not available right now.
The conclusions,
Yeah.
no inscription of
Can
the
you
actual views.
Yeah.
But patient has.
Can you see the images?
Yes.
Yeah. So this is a PSMA SPECT scan from 2019, because at this time there was a possibility to image in the National Cancer Institute PSMA with SPECT. So this is our images, and there is a very high lesion in the prostate with very high PSMA expression. Also, we found the pathological lymph nodes on the right side of the pelvis. Also, the PSMA expressing lesions in para-aortic space, and also one lymph node in the right lower paratracheal space. And this patient, 2 weeks later, underwent PSMA PET SPECT in Riga, and the data, the report from PSMA PET was identical to our findings. So PSMA expression lesion in prostate, in right pelvic lymph nodes, para-aortic space, and lower paratracheal lymph node. This is the initial PSMA scans before treatment.
And as I correctly understand that urologists don't suggest surgery, local surgery.
According according to your recent findings, it's clear that from the beginning, from the start, it was a, let's say, metastatic disease. Metastasis outside the pelvis should be evaluated like M1A disease. So obviously there is no evidence-based place for localized therapy to the prostate. Even the first year attempt to irradiate prostate is out of label. It's experimental treatment. I think that the basis is a systemic therapy, ADT, and then next therapies. If it is placed to do some additional salvage for the prostate, nobody can't answer. You can use it, but it will be very experimental. As I said, for me, it seems that typically if we see the pathological lymph nodes in the pelvis, we do not remove them. We prescribe radiotherapy to the pelvis and to the prostate together with hormones, high-risk prostate cancer. If there is lymph nodes in it's metastatic disease. It means ADT plus, as I said, chemotherapy or abiraterone, blah, blah, like that, according to our day knowledge. Of course, your case was 2019, yes? 2 or 3 years ago. So probably our understanding was different. But anyway, the localized therapies for the prostate, according to Stampede trial, is feasible only in oligometastatic disease, when you have 1 or 2 metastases. Here it seems a lot of lymph nodes are injured. And I think that still metastases in lymph nodes exist. Probably they are too small, micro. Their metabolic activities are impaired because of ADT, and so you can't see them on PET-PSMA. But anyway, it's metastatic disease. I have doubt if there are any additional local therapies will benefit the patient. So I think that we should act according to the guidelines, wait for the radiological improvements of the progression, and then go probably to the chemotherapy.
Yes, I would agree with Professor completely. I think it's the stage 4 prostate cancer from the beginning, high risk, high volume. So the decision that docetaxel was used, it was the right decision. And local treatment at this point would be, there's no data supporting this sort of treatment.
Actually, that is very good, nice example how PET-PSMA at the moment, if we do it not according to the guidelines, because guidelines telling us that PET-PSMA should be used for local recurrences after radical therapy. But of course, modern life was looking for new indications. They do it looking for the metastatic disease from the start of the disease, as I understand. It's out of label. We never use it. And now we have very confused strategy of the treatment, because we very early in the course of disease find the spots. But actually, our strategies are built on conventional CT and bone scan. Can you compare, let's say, how was in the beginning of this disease, how was looking CT and bone scan for this patient?
The bone scan was performed, but it was negative.
Negative, yes.
Yeah.
Negative. Yeah. And our, let's say, all strategies are based on these findings. So with PET-PSMA, I don't know, it might ruin our understanding of our strategies. And so at the moment, nobody can say how it will look like when we will start to use it in every day for every patient looking. Even for these patients, they are doing PET-PSMA to evaluate the dynamics of the patient. Okay, where he's doing these investigations, here in Lithuania or in Norway? Or let's say
it was done in Riga, and the last was done in Frankfurt in Germany.
Yeah, we have also one such patient in our clinic, and also we have a lot of questions with him. because of these new modern radiological evaluations.
Thank you very much for your opinion. Maybe he has some comments, radiation oncologist.
Probably we could follow the case.
Okay, next please.
And I have thoughts about PSMA PET. So we should keep in mind that we see only lesions that are more than 5 millimeters in size. So if we have not localized, but of course systemic disease, so what we saw on PET as M1A, so probably there are present more lesions than we see on PET. So evaluating this patient today with no lesions in other lymph nodes higher than pelvis, it doesn't mean that we just see them all. Probably there are micrometastases present still.
Okay, so probably we can continue.
Okay. Thank you for your comments, and I will continue of treatment the patient was given. It was carbon-ion radiation therapy that was given in Austria in November 2021. Also, local cryoablation was performed in December 2021. And following therapy recommendations was meclotamide, 1,050 milligrams oral daily, and triptorelin injections every 3 months. I should state that carbon-ion therapy is a novel therapy, is not a standard of treatment, and only 13 centers in the world perform this. And here you see PSA levels, dynamics. PSA dropped to the 0.21. And recommendation was formulated after salvage therapy. So it was pelvic MRI after 4 months, PSMA PET-CT, not earlier than 9 months after this therapy, considering PSA dynamics, and also regular follow-up by urologist.
I would like to ask, maybe this patient was overtreated?
Well, this, as I said, I follow the patient, prescribe the tests and the hormonal therapy, and other tests are considered in accordance with the doctor's radiotherapist from Norway. And that's he had the second opinion in Austria, in Vienna, for this treatment localized. Also, it was supported this idea to go ahead with this second local treatment.
What about his status of life, of quality of life?
Quality of life. Recently, I saw the patient last week, and he said that he had some rectal bleeding, and so this is now. We'll have to check on this. Otherwise, quality of life, he's in good health status in general, no symptoms.
What urination condition?
Recently, he didn't indicate something.
It's nice that we can collaborate with our colleagues from Norwegia, but I think that sometimes, maybe in this case, this patient was overtreated with radiation therapy. I'm radiation oncologist, but as far as I know, for example, prophylactic breast irradiation, no efficiency about benefit of it. And And for salvage treatment, in this case, PSA level was low, and I don't think that he needed salvage therapy. It's my opinion.
Yeah, so I agree.
Could you share maybe your own opinion? About local treatment was been done.
Žygimantai, you are asking for whom?
Maybe you, Professor Jevaltas, what your expression about treatment of this case?
As I said previously, together with Dr. Ulis, we did a lot to establish the salvage therapy after radical therapy for localized disease. Yes, we have some evidences after radiation therapy without any metastasis, I mean the hormonal sensitive prostate cancer, localized cancer, after irradiation, salvage, thermal therapies, doesn't matter, HIFU or cryo, they have their role and they have some evidences. But in case of systemic disease, that is very experimental. I'm not against that. Yes, I for that, but these patients should be included in scientific protocol. And my question for your institution, do you have such protocol, such trial? Are you a part of multinational study or a center for that? If not, I'm not, but probably this patient was included in such trial in Austria. We should collect data in order to have more experience, in order to conclude something. So my approach, these patients, we should try to do something. We should include protocols, but at the moment, there is no data and guidelines about such therapy. Such therapy still is valuable, experimented. Of course, I would like to wait a little bit, but because after thermal therapy, some complications appear after some years. At the moment, I'm treating in my department my patient who was experienced cryoablation in your institution 6 years ago. And now complications started only after 6 years. So now it's just the beginning. We will see, because there is a big risk for urinary retention, for strictures, even for the fistulas formation. So wait a little bit. Of course, the PSA, it seems that respond to the treatment, and if we will avoid any local complications, okay, we will evaluate that like a good result.
Thank you for opinion.
But as I said, it's experimental.
And I have even a question for his physician, medical oncologist, Dr. Brasiūnas. Was local therapy as experimental or daily common practice in Austria?
This is a center specialized in this treatment, and it was also the consultation of the radiotherapists from Norway who had consulted together with the Austrian doctors, and their decision was to proceed with this treatment.
It's like a common daily practice.
Yes.
Stage.
It's one of these centers that I don't have too much information about that center and their programs, but that was the case where the patient was directed to the center.
Maybe more.
Okay.
Maybe some colleagues would want to tell something about this case, or?
Yeah, thank you actually for very good example how new technologies are gonna to ruin our previous understanding. But actually that's a normal scenario. New findings are gonna to change our practices. That's normal thing. But once again, especially National Cancer Institute or our institution also, we have a privilege and also responsibility to initiate the new trials, to collect this new data, especially about not very clear clinical situations, in order to progress, in order to provide new information. So thank you for all these 3 excellent cases. They are not very typical, but in that point they are very interesting. Thank you.
Thank you.
Thank you very much for your attention. We will end MDT, yes?
Thank you for your comments.
Okay, thank you.